Hello students. In this session, we'll discuss about poliomyelitis immunization part, such as prophylaxis of poliomyelitis we'll discuss. In the previous video, we have discussed about morphology, pathogenesis, and a laboratory diagnosis of poliovirus we have discussed. So immunization part is very important one. Most of the times, you will be getting this question for either short question or very short question, and even it is important in the Viva also. So here, for prevention of poliomyelitis, two type of vaccines are available. The first one, live vaccine, and second one, killed vaccine. So killed vaccine, that is SAX IPV. IPV means inactivated polio vaccine. And the second one is live vaccine, that is Sabin's vaccine, that is OPV, oral polio vaccine. So both live vaccines and killed vaccines, they give the protection from the poliomyelitis. Then what is the difference between live vaccines and killed vaccines? So in case of killed vaccine, they induce only systemic antibody response, or they give only systemic immunity, which means in case of killed vaccine, only humoral antibodies, that is IgM and IgG antibodies are produced. So there is no local antibody protection. And as you know, IgA is the local antibody. So IgA is not produced in case of killed vaccine. And in case of live vaccine, so they induces both like a local immunity, which means they produce secretory IgA antibody, and on the other hand, they produce humoral antibodies, that is IgM and IgG antibodies are produced in case of live vaccines. So in case of live vaccines, three antibodies are produced. One is IgA, IgM, and IgG. In case of killed vaccine, only two antibodies are produced, that is IgM and IgG. So first of all, we'll discuss about killed vaccine, that is SAX IPV, inactivated polio vaccine. So it was developed by the scientist SAC in the year 1953. So this vaccine consists of formalin inactivated preparation of three polioviruses. So as we discussed in the previous session, poliovirus, it has three serotypes: serotype 1, 2, and 3. So these three serotypes, they are grown on monkey kidney tissue cultures, and they are inactivated by using of formalin. And each dose of IPV, which means generally we'll give 0.5 ml of IPV, they contain total 80 units of D antigen, that is dense antigen of all the three poliovirus serotypes. So total 80 D antigen include 40 units of poliovirus serotype 1 and 8 of serotype 2 and 32 units of serotype 3. So total 80 units of D antigen present. They include, so poliovirus type 1, 40 units, and type 2, 8 units, and type 3, 32 units. So total 80 units. So here, what is the dosage? So how much it is given? Generally, it is given as either intramuscular or intradermal injection. So in case of intradermal injection, generally we'll give 0.1 ml of FIPV, that is fractional IPV, inactivated polio vaccine. It is given at the upper arm. And in case of intramuscular, so 0.5 ml is given at the anterior lateral side of the mid-thigh. So under NIP, under National Immunization Program, so in India, 2 doses of FIPV are given, like that is fractional inactivated polio vaccine. It is given intradermal at 6 weeks and 14 weeks along with the oral polio vaccine. So how much dosage it is given? That is 0.1 ml is given. So generally in the year 2015, IPV was introduced. So in the year 2015, we used to give only single dose, like full course, intramuscular route at the 14th week along with the like a bivalent OPV. But from 2017, FIPV, that is fractional inactivated polio vaccine, is introduced It is administered by intradermal route at the age of 6 weeks and 14 weeks along with the OPV. So why they have made this change? Because of the if we give the intradermal injection at the age of 6 weeks and 14 weeks, it's shown to provide the higher seroconversion rate than the single full dose of the intramuscular, which is given at the 14 weeks. And not only that one, cost saving, because like a 0.2 ml per 2 doses of FIPV is given. Suppose if we give intramuscular, we have to give 0.5 ml. And if you see, the IPV has efficacy of 80 to 90% on full course of the vaccination. And so this vaccine produces the long-lasting immunity to all the 3 polio viruses. So as we discussed, they induces serum antibodies, which means humoral antibodies. So only IgM and IgG are produced, and they does not induce the secretory IgA or local IgA antibody. IgA antibody is not produced. So what is the main advantage of this vaccine? So what is the main advantage of this vaccine? So it can be given to the immunocompromised individuals. Immunocompromised individuals means, so those who are having the less immunity. So for them, we can give this IPV because it is safer to the immunocompromised. So in case of pregnancy also, and in case of the old age also, we can give. But what is the disadvantage of this IPV? So what is the disadvantage of this IPV? They does not provide the herd immunity. What is meant by herd immunity? That is a community immunity. Because why they does not provide the herd immunity? Because it is inactivated. The virus, it is inactivated and it cannot spread by the fecal-oral route, and even it is not useful during the epidemics. So why it is not useful during the epidemics? Because there is no community protection. And it is little bit expensive than the oral polio vaccine. Next, second one, live vaccine, that is Sabin's OPV, oral polio vaccine. It was developed by the scientist Sabin in the year 1962. So it consists of all live attenuated strains of poliovirus type 1, 2, and 3. So it consists of 3 serotypes. The virus, it is not inactivated completely. So just the virus, it is not completely killed. So it is attenuated, which means their pathogenic nature is attenuated, but they retain their antigenicity. So these 3 viruses, they are grown on either monkey kidney cells or human diploid cells. So generally OPV, they consist of type 1, 10 lakhs, and type 2, 1 lakh, and type 3, 10 lakh virus particles. So nowadays we are using only bivalent vaccine, which means it consists of only 2 serotypes. Generally we use type 1 and type 3 only. So in case of bivalent vaccine, type 2 is not included. And what is the route of administration? The route of administration is oral. It is given as 2 drops. And what is the main advantage of this vaccine? So the main advantage of this vaccine is they produce a local immunity, which means they secrete, they produce local secretory IgA antibodies, and humoral antibodies are also produced. That is IgM and IgG antibodies are produced. And see, as it is the live attenuated virus, means live attenuated strain, the virus, it is excreted in the feces of the vaccinated child, and it may spreads to the close contacts, and as it spreads to the close contacts, it will protect the individual as well as the community, which means it will provide the herd immunity also. So nowadays only we are using bivalent vaccine, which consists of type 1 and type 3 of OPV is used. So here, what is the route of administration? What is the route of administration? It is oral. So that's why it is known as OPV, oral polio vaccine. So it is given as 2 drops. So dosage, how many doses are given? Total 5 doses are given at birth 0 dose is given, which is also called as hospital dose or institutional dose or birth dose. And at the age of 6 weeks, OPV first dose is given. And at the age of 10 weeks, one more dose is given. And at the age of 14 weeks, OPV third dose is given. And booster dose is given at the age of 16 to 24 months. So total here 5 doses. So at birth, at the age of 6 weeks, at 10 weeks, and at 14 weeks, and booster dose is given at 16 to 24 months. So under NIP, under National Immunization Program, so 0.1 ml of FIPV is given intradermally at the age of 6 weeks and 14 weeks, along with the bivalent oral polio vaccine. So these are the differentiating features between the OPV as well as the IPV. So if you see in case of virus, if you see the characteristic virus, so in case of OPV, so OPV is the live attenuated, which means the virus it is just attenuated, which means they do not have ability to produce infection. Their pathogenic nature is attenuated, but they retain their antigenicity. But in case of IPV, the virus it is completely killed. And in case of safety virus, so OPV is not safe in case of immunodeficient. So those who are having the less immunity, or otherwise in case of pregnancy, or otherwise any other health conditions, OPV is not safe. So why? Because the OPV consists of live attenuated strains. And in case of IPV, IPV is very safe, that can be given to the immunodeficient persons. And if you see the efficacy, OPV, it has 90 to 95% of the efficacy. So we can say it has almost 100% protection, and IPV has 90% efficacy. And if you see the administration, so OPV is given as oral, and IPV is injectable, whether it is given either intradermal injection or intramuscular injection. And if you see the economy also, so here OPV is cheaper, okay, and IPV is costlier. And to give the IPV, we need the skilled persons, and we need resources also. But OPV is we can give it very easily. And in case if you see the nature of immunity, so OPV gives both the systemic immunity as well as the local immunity. So systemic immunity includes production of IgM and IgG antibodies, and the local antibodies such as IgA antibody. And in case of IPV, it gives only systemic immunity, which means only IgG and IgM antibodies are produced. And the duration of immunity, so OPV is the long lasting and IPV is the short lasting. And use in epidemic, so yes, OPV is useful and IPV is not useful. And storage conditions also, so OPV is it should be stored and transported in the cold conditions. So 100% cold chain we should maintain. So they should be stored at -20 degrees centigrade, and they are stabilized by using of magnesium chloride, and the pH should be maintained at less than 7. But in case of IPV, so it is very stable, and they does not require any stringent storage conditions because it has a longer shelf life. So here, what are the main advantages of OPV? Here, OPV provide the herd immunity, which means so the virus it can shed in the feces and they spread in the community by the fecal-oral route. So that's what it induces the herd immunity. And the main advantage is it is cheaper than the IPV, and it is easy to administer also. It can be given by the oral route. So what is the disadvantage of OPV? So OPV is we cannot be given it to the immunocompromised people during the pregnancy as well as in the old age, and it should be stored under the recommended conditions or cold conditions. And next, if you see the efficacy of OPV vaccine, it decreases by interference with the other enteroviruses. In case of other enteroviruses infections, so the efficacy of the OPV vaccine is decreased. And in case of diarrhea also, suppose in case of diarrhea, if we give the OPV vaccine, but OPV vaccine will be washed off in case of diarrheal stool. And so even though the child is having the like a diarrhea, we should give the OPV vaccine, that is for community protection, and the dose should not be counted. And after recovery from the diarrhea, again we should repeat the like a dose, like again the repeated dose should be given. And in case of breastfeeding also, so the OPV gets washed off away in the stool immediately or before and after the like breastfeeding. So suppose if the mother give the breastfeeding either immediately after the vaccine or otherwise after the before the vaccine or after the vaccine, it is washed off. So that's what breastfeeding should be avoided at least 30 minutes before and 30 minutes after the like administration of OPV. And the main disadvantage is they can cause vaccine associated paralytic poliomyelitis, that is VAPP, and vaccine derived poliovirus VDPV. So as we discussed, like VAPP and VDPP. So as you know, like OPV is very safe, like it is extremely safe and effective vaccine. But in very rare cases, it may causes the like a vaccine associated paralytic polio, that is VAPP. So it is caused by the strain of poliovirus, like which is genetically changed in the intestine. So here, so in the OPV we use the like original vaccine. So in the intestine, the original vaccine undergo the genetic modification, and because of that genetic modification, here like the new strain will be developed. So this strain is named as VDPV, which means vaccine derived polio virus. And sometimes this strain develop the capacity for sustained circulation, which is called as circulating VDPV, CVDPV, which means a circulating VDPV. So due to the risk of CVPDVS, OPV must be phased out to secure the like a long-lasting prevalence. So currently, type 2 strain, it has been eradicated. So currently type 2 strain in the OPV accounts for more than 90% of all CVDPV cases. And as I told you, like it has been eradicated since 1999. So under like a national immunization schedule, so as we discussed, total 5 doses are given. And along with that one, generally like this under the part of like a pulse polio immunization program, we give like 2 doses of polio drops. So irrespective of their polio vaccination status. So 2 rounds of polio vaccine immunization are scheduled every year. So as a part of this pulse polio immunization program, so the children under the 5 years, they are vaccinated with the OPV. So we are not supposed to count these doses. So irrespective of these doses, we should give the like 2 doses under the pulse polio immunization program. So if you see the epidemiology, so poliomyelitis, like it is exclusively human disease, so it can be eradicated. So because it is exclusively human disease, and humans are only the like reservoirs or asymptomatic carriers. And if you see the feces of the patient, or carrier, so it is an important source for dissemination of poliovirus in the community. And not only that one, so this virus, it also shed in the like pharyngeal secretions, and warm weather, it favors the spread of the virus. And as we discussed, poliovirus type 1 is responsible for most of the epidemics, and type 2 and type 3 eradicated from the world. Next, eradication of poliomyelitis and pulse polio immunization program. So poliomyelitis, like it can be eradicated because man is like only host. So here OPV is suitable for poliomyelitis because it is to eradicate the like poliomyelitis, because it is a live vaccine virus. So as it is a live vaccine virus, so after giving of the vaccine, this vaccinated virus continuously multiply in the gut of the vaccinated child, and it can interrupt the transmission of wild poliovirus, which means if wild poliovirus enter into the stomach by the contaminated food and water, so this vaccinated virus can interrupt the transmission, And see, this vaccine virus is also excreted, and this virus also can transmit to the like close contacts. So that's what like those who are not immunized. So as this vaccine virus is also excreted in the like stool, so it can transmit to the like other children who are not vaccinated. So to avoid this one, here simultaneous administration of vaccine is given, which means like we'll give the like vaccine to all the children in a region or in the particular place on the same day, like it is found to be the like useful. So this is the basis for pulse polio immunization program. So pulse polio immunization program, so it is launched in the year 1995 in India. In India, it is launched in the year 1995. So as we discussed, under this program, all the children under the age of 5 years, they are given 2 OPV drops irrespective of their polio vaccination status. So previously we have discussed, according to the like national immunization schedule, 5 doses are given. So irrespective of that 5 doses, so we'll give the like 2 more doses. So 2 rounds of pulse polio immunization are given. So every year, so there should be a minimum gap of like 6 weeks in between first and second dose. So polio situation in the world. So currently, like polio is endemic only in the 2 countries. One is in the Pakistan and another is in the Afghanistan. So polio has been eradicated from India. So since March 2014, that's since March 2014. So there is no polio cases. So that's what WHO declared, that India is free from the like of polio. So here the Global Polio Eradication Initiative, GPEI, it is launched like with the aim of the polio endgame strategy 2019 to 2023 for polio eradication and sustaining a polio-free culture. So this is the end of the session. So if you see, poliovirus is the causative agent of poliomyelitis. It is classified into 3 serotypes: serotype 1, 2, 3. And the virus enters by the ingestion by contaminated food and water, and by inhalation through the respiratory droplets, and rarely by conjunctive also. And the laboratory diagnosis is done by direct demonstration of the virus and serology. In the serology, we detect the like specific antibodies. So 2 types of vaccines are available to prevent this poliomyelitis. One is killed polio vaccine, that is SAX-IPV, and second one is live attenuated oral polio vaccine, that is Sabin's OPV. Thank you.